was, this morning's been amazing, and that was just so reaffirming of all the things that I've learned and done, and that was the best synopsis of all that ever.
Exactly. It's, I mean, every time I watch Mariano, I learn something. I love Patricia, and we're very big in my practice with all of these early intervention.
You prefer this one with flowers? Pura Vida is my wife, but it still have orange.
Cute.
I know, it's extremely...
And then I can go for the Harley that is still having some orange. So I think this is gonna be.
I don't think, Jeff, I don't think he knows what deadheads are, but we'll tell him about it later.
Yeah. I guess I should get started.
Yes, please. My wife is killing me. Move, don't talk more. Go.
Yeah, give me the 5-minute
marker, yes.
When we're at 5 minutes, okay?
Perfect.
All right. 1:55, so let's do it.
Okay.
Oh, where?
First of all, good morning or afternoon, wherever we are in the world. And here I was supposed to talk about bioaesthetics, 25-year kind of review of principle, guidelines, techniques. I'm going to try to speak Spanglish. I'm going to speak really fast in English because, wow, how can you do 2 or 3 hours in 30 minutes? We're all trying. Yeah, that's me. I just love this idea from Bateson, from Mike Gunson. Everything's about patterns, connected patterns, and it's all a life's of dance. When we're thinking about health of the individual, and we're thinking about occlusion, I don't think about teeth and what I learned in biology first. I think about what I learned from Fritjof Capra about system, the understanding of living systems, and how what matters in a living system is connectedness, relationships, and context. And so what I learned so long ago and what I do today, I still use biology, try to use biology as my guide. And that's why I like this idea of bioaesthetics. And I like the idea that the whole has a property and none of the parts have the property of the whole. And the properties, the patterns that we see are interactions from relationships of the parts. And if we try to just measure one part of the system, we're going to miss the dynamic interplay of all the parts. I want to share with you 2 or 3 quick ideas. I've been changing this presentation since the morning. Gracias, Javi and Hamid. This has really been an amazing marathon, and I'm in for the day. In 2002, I started treating this patient. She had a full mouth reconstruction failing, and over 2 years we placed implants, and I got all my dots in the right place, and I had all the guidance right, and I even thought I had done a pretty good job in the day with the technology I had, and then just a year and a half ago, I remeasured the patient, and I said, hey, you know, what happened? You, for the first time in 17 years, you chipped a little piece of porcelain, only one piece in 17 years. And I'm like, how did that happen? I went back through my process of measuring and looking, and I said, this, you're gonna love this, Mariano, Peter. The buccinator is being violated. My second molar in the back, the fibers can't get around, and it's interfering and throwing things off. Why does my patient love her splint so much? Because look at the ceph. I mean, not look at the ceph, look at the cone beam, look at the change in airway with and without the splint in 2018. It goes from 46 to 252. What did I do? All I did was I put a piece of plastic in between the maxilla and the mandible, and the whole system changes. These 2 scans were taken less than 5 minutes apart. It's a dynamic system, and it matters, thank you, Bill Arnett, where the occlusal plane is oriented to the face and to the lips. That's my, oh, geez, I could stop right now. So how do I practically use everything I've learned in the last 25 years using this idea of bioaesthetic dentistry, which I'm going to talk about in a bit, but what do we do? for the last 5 years, I've had an occlusion workshop for the PG perio residents at NYU. And this year we broke this down so simply. How do we make an appliance? How do we make a splint? How do we put something between the maxilla and mandible? An Essex aligner with some flowable on the front to create a jig, and just get contacts on the front, and then posterior contacts, and then add canines, and then you can sequence through. How am I doing? Too fast? Oh, there. Now, and what does it look like? In less than an hour, here's the patient. Opens and closes. And slides left and right. He learns that mandibular behavior posture. How does that happen? Why does it happen? Because occlusion or mandibular movement is a learned behavior with the eruption of teeth and the proprioceptive feedback, mechanosensory feedback to the cortex. So in life, what's been our challenge now? Trying to change from an analog to digital world, and we always have to measure. And now we can use digital to measure things. But ultimately, when we look at the patient and we try to see, has this child grown well? This is why I'm just so amazed that I'm following, Patricia, because the measure of how well that child grows is what Dr. Lee did in his lifetime. He measured babies that grew to be 60, 70, 80 years old. And what he found was they had really well developed arches, had little or no wear on their teeth, good functioning operating joints, and they had really attractive smiles. So there's this like link between being born and being 60 or 80, and that's all the caca that happens to us in life. And so where do I start trying to figure out how to get this great system in the patient's mouth, or do they have a great system? Well, we just look at the front. They look at the front two teeth and see, has the maxilla erupted forward and down out under the upper lip? And if it isn't, then I'm going to start to try to imagine where that could be. And I even developed a little app that I can put a template on my picture in live time, and I can measure 80% and see where's my incisal edge on my midline, and I can see where should my tooth be, so that I can start to plan. And so I loved what Patricia showed with the eruption of the first teeth, the primary teeth, that they start to create like a fence, or hey, here's where my jaw goes, and back and forth. And what do I do when I make a splint? When I'm trying to first start with my patient, Javi, I make this Essex aligner, I make this little anterior jig, and I get two contacts, two lower incisors, left side, right side, and I touch, and they slide forward and back, because they remember that. The brain remembers when they were a child. They remember learning that forward and back posture, and that's easy for the cortex to remember. And then if you put the teeth in the right across the aesthetic plane, 6, 8, 9, 11 feline that I call it, you can then develop that new anterior incisal edge. You put that in the mouth, and how do you do that? You start open and close, open, close, slide forward. If their lips and teeth, the brain already knows where they want to be, and so that's my first jig. And then from that, I can create two incisors, the contacts back at the 6-year molar, because what? That's the first permanent tooth that erupts, that starts to create a more vertical chewing cycle. And Dr. Lee, this idea of bioaesthetics, he called the mandibular first molar and upper first molar the first canines. They're the first verticalizing input to the brain that stops the horizontal chewing pattern of the child and starts to make it more vertical. All of our closing is occluding into and out. It's just a matter of how far across the teeth we go, and we're going to get to that in a second. Okay, so there. And then there's the appliance I make. Tap. Slide forward and back. Slide forward and back, left and right. And then smiley smile. Is that cool, Hamid? Give me a thumbs up. Not bad. And what does that look like when you look at the patient? You put that, here she is, and now you put the appliance in her mouth. Watch the lips change. The lips change to the hard tissue position of the teeth. The splint isn't designed to try to fit hard tissue to where the lips are. The lips are a functional response to where the hard tissue is. And that's why the mandibular sling for Mariano and that Peter just blew my mind when some of the pictures they had are better than the pictures I've ever found in the last 5 years. Amazing, this mandibular sling and this frenum here and this, how this is tethered. That tethers us. We're worried about this tether and that tether, the tongue tether. The ring is a tether. That's what Mariano told me that Ricketts told him. So this idea of getting front teeth in first and then doing things in the posterior was what Dr. Lee sort of liked as an idea. And so this idea of bioaesthetics was from Dr. Lee, the study or theory of the beauty of living things in their natural form and functions. And so we have this idea of how we think well-developed systems. The little kids that Patricia just showed you, the biologic sequence of growth and development to have teeth and the cortex learning skills as teeth erupt, they can, when they last a lifetime, we look at the beginning, we look at the end, and we say, geez, can we keep them together in between? We have these 3 test positions. The incisive, it's not slide out, it's open and move forward to and then back from. When we go to the right and left to chew, we do not slide out. We occlude in. We open, we move laterally, and we close back in. And depending on the quality of the contacts and the position and alignment of the joints and the dental alveolus and the teeth, the mandible spends more time in an occluded position as it moves in and out to pause to swallow. And so when we put that tooth form and fit and function into the face, we realize that the orientation of the teeth is to have a slight 92 to 96 degrees inclination of the occlusal plane relative to the vertical line to the face. Where do some of these ideas come from, or these new ideas? Is technology new? It is not. The Panaden articulator was developed by Bob Lee and created motion analogs that were based on how human jaws moved. They had computers hooked up to jigs on the maxilla and mandible, and they had people chewing food, and they measured the movement of the mandible in all 3 planes of space. And you can find that in this book, Function of Teeth. And what did Lundin and Gibbs find and publish in 1982? That an individual system chews different foods differently. Francesca, exactly. We chew gum differently than carrots and cheese. So the patient has to have different food because their envelope of into and out of function is going to be different. But at the end of the day, the movement in and out, the occlusion in and out is really, really defined for a patient that has verticalized tooth relationships. What happens when those horizontal relationships in the front change and become more horizontal? You see, now you take 3 different systems and they all chew cheese. And when they all chew cheese, it's different. A good occlusion with, I'm not gonna say canine guidance. I will not say canine guidance. Because since the child was born, the tongue and the lips have been guiding the jaw. The mandible doesn't suddenly decide that it has canine guidance. The mandible and maxilla develop to a point that when the upper canine comes in at age 11 or 12, it erupts down into that vertical relationship, creating canine guidance. The canine guidance has been there since the first molar came in, and it was there in the primary dentition, but it was much shallower. So this idea of canine guidance, we just got to throw that out. We have to think more biologically. We got to think more like, how does this system work dynamically? not canine guidance. It's just the most vertical guiding tooth. How does a system chew? Well, you know, people make videos, and this is my favorite video. A patient that has been restored to a system that meets the tenets of the biologic model, 3 or 4 millimeters of overbite, 2 or 3 millimeters of overjet on the incisors, 4 or 5 millimeters of overbite at the canine, 0.5 millimeter to 1 millimeter at the canine. The patient is never locked in. They're only locked in if their disc dislocates. All you have to do to unlock the fit of the teeth is to let gravity, let your jaw sag. People aren't trapped in there if there's not, they're trapped when there's not enough overjet to have an envelope to move in. Watch how this patient never touches the canine. That's how Dr. Lee could measure people that were 60 to 80 years old with little or no wear on their teeth. And yet other people that do have wear, what Lundin and Gibbs found was that those people chew and parafunction across the facets that are on the teeth. That's really, that's from 82. So, and all of that, I showed you this patient who, what? She, 17 years later, I look and say, God, I missed the occlusal plane. And that's what we're all trying to do ultimately in our treatment. We're all trying to reestablish an occlusal plane, relationship of mandible to maxilla that's in balance with the neuromusculature and ultimately the airway. And when we talk about airway, just remember that from the top of the posterior pharynx down to the epiglottis, that space that some people say is the airway is also our tube that we swallow in. So we do a lot of functions up and down in that tube. And then at the epiglottis, our biology says, food go this way, air go that way. From our lips to the epiglottis, food can go that way and air comes back up the other way. And then we have phonetics and articulations where we make sounds across the positions of the teeth. This was a patient then that I'm going to share. That's 3 time points. Post-jaw surgery, 5 years. A bioaesthetic composite restoration, and then changing all those tooth forms to maximize tooth form, fit, function, and most importantly for her, color of teeth. So principles are the things that underlie what we do. Gravity, we can't beat it. Principles, guidelines, techniques. So form of the joints, form of the teeth, and form of the occluded dentition. And in that idea, I think I already just went through some of these numbers: 11 to 12 millimeter central, 9 or 10 lower central incisor, and that should create this idea of this 4 millimeters and 2.5, 3 millimeters of overjet. And if you measured that from CEJ to CEJ as a referent, then that would be 16 to 18 to 20. The math there is for a class 1 cranial base to mandible relationship. It's going to be about 18 millimeters. You can measure all those things on models and in old Cephs, and now with our technology, we can see at the end of our treatment, how did I treat this patient? How well, what's the position of the condyles? Form of the joint. What's the form of the occluded dentition? Do I have axial loading? Is my transverse been done well? Did I need Mariana to expand this, maxilla to meet the mandible or not? And then ultimately, where is that upper incisor, lower incisor, that overbite, overjet? How is it projecting the lips forward so that they can gently seal efficiently and allow us to breathe through our nose? And when the anterior relationship of the mandible is off, the lips are going to compensate and they're going to upregulate neuromuscular activity, and that's going to affect the quality and quantity of how the air passes through the nose and through the system. And sometimes as a response to that, we're even going to have mouth breathing because our upper airway resistance, which is a series of constrictor muscles that comprise the airway, have been challenged, and they are always going to try to win, and we will breathe through our mouth when we can't breathe efficiently through our nose. So why do we use an appliance? We use it to stabilize the jaw, because what we realize is the patient learns to put their teeth in the best position that they can to survive, and that if something's in the way, they're going to find a place to balance tripod, front teeth, posterior teeth, and the condyle. And when we do that, we can measure that with technology, analog or digital. Doesn't matter how we do it, we need to measure it, you know? But not everything that matters is measured. Not everything that's measured matters. And so what we have to do is create workflows and criteria, metrics, that we all sort of agree that, hey, we're going to measure this. We don't need to measure that. Hey, what's really important here? So this is, I'm going to slow down just for a moment. This is Sarah. And she always asks me, did you show me wherever you went? And it's like, I didn't go anywhere, Sarah. I stayed home. Her story started in 1980. She's a school teacher, and we have pictures of her for the last 40 years. There she was, and then she had an car accident. And after the car accident, she had silastic discs placed. She had corrective jaw surgery and a rehabilitation. And then over time of about 15 years, the anterior teeth started to chip and break, and she started to become a little symptomatic. And the orthodontist that referred her to me, Milt Berkman, who was my first Roth-trained orthodontist that I learned to work with, and we developed concepts of treating patients together. He referred her to me, and then I was kind of responsible trying to help take care of her. We used these ideas that Dr. Lee had, systems that last a lifetime, with little or no dentistry, with little or no wear. The idea could be simple in terms of thermodynamics, first and second law. Enamel's the hardest substance in the body. When there's wear on the enamel, it's either sign of adaptation, it's sign of stress, it's a sign of a problem, it's a sign of misalignment. Put the word to it, whatever you want. My goal for my patients is to try to get all the right teeth in the right place and the right timing for the best function they can have. Where does Spear, Kokich, and Matthews say you should start all this stuff? Where the upper incisor is. And so when you put that into the occluded dentition and you draw that line from canine tip to canine tip, I call that the functional aesthetic edge, and Bill Arnett calls that his ruler test. But it's the horizontal. It's the horizontal line of the occlusal of the maxilla. Where is it? You can look down on it and see that there's a curve, and you can have the curve in the DSD template, but ultimately when you look exactly perfectly at the incisal edge, it's a line. The line is defines the edge of the plane. And for me, that's really critical. And then that's really important in the biologic model, because the canine, the two centrals in the canine, for this concept or this functionality of how the mandible moves, have to be on the same horizontal line. Otherwise, the distance that the condyles move isn't symmetric. You can't chew as well vertically and symmetrically. And so any other relationship you have there just creates adaptation. We had this just breakthrough at NYU with Jonathan Levine. We had a patient that was going to go through be our demonstration for some veneer preps, and it was like, hey, let's start with aesthetics, and then let's make an appliance that puts the mock-up in the mouth, but let's use an Essex aligner, 1 millimeter thick, but we have the fee line in the front. So some people say, oh, it's a snap-on smile. It's very thin. It's really cheap. You can make it yourself. You don't need a lab, and you learn by doing that. The Essex aligner, when you make the canine that length that matches the central that you would want to have for a nice smile, look what it does to the opposite second molar. It creates space. And there wasn't space there in her occluded dentition when she moved out and back into that canine tip-to-tip chewing simulation. Look at the space she has. With something that's thin, it does not have to be 2 or 3 or 4 millimeters thick. has to fit the biology, and the biology can't be violated. There, interference-free movement of the mandible by only putting in a 1 millimeter thin piece of plastic. So what's occlusion? It's the blockage or closing of a blood vessel or hollow organ. And what do we have in a functional occlusion? From the lips to the teeth together, tongue to the tip of the incisor papilla, back to the pharynx, tip, tongue, teeth, lips, teeth, tongue, throat, thorax, thighs, toes. Hang on for another hour, and Darich here is going to talk about lips to teeth to toes orthodontics. Okay? And all of that comes back to this idea that Peter just demonstrated so well. And I just loved how I now understand even better how important the raphe is for when the mandible opens. Because this is the ring, the constrictor ring that we really ultimately have to worry about. And maybe that's why the lower lip and the tongue and the frenum develop their ties, because ultimately that ring is tied. It's a real bigger noose than those others. It's a way bigger system of muscles. So all that in mind then, the idea of dynamic equilibrium, splints, orienting the occlusal plane. I see I've got about 5 minutes here. My point for all this for the day was to try to show that integrating these three models or ideas of neutral zone from Dawson, the biologic model, bioaesthetics, that I tried to show you the functional test positions, and then looking at the face, soft tissue facial analysis from Arnett and others, and looking at the face and seeing how is the support making the face look. We work backwards from that, and we start with our vision of our best, 530. That's a dynamic, that's a BMW, that's a functional smile machine. That the BMW 530, that's the ultimate smiling machine. And then we put these systems and biology behind it, and we start to appreciate that, hey, the further forward the anterior teeth are, the better the airway is, and that's the root of Bill's planning. So we have all these things here, and let's see, I jumped out of that. I want to go to shim challenge. How do we ultimately, how do I fine tune things if I don't have a T-scan, and I'm using articulating paper? Dara and I are going to talk about shim challenge. And the shim challenge is using these dead soft foils from Buffalo Dental. They come in thicknesses 003 and 001. You place those in and get contacts in the two incisors. And what those are going to do is they're going to separate like a class 3 lever. You put them in until you don't have a posterior contact. You measure what the contact is. Patient slowly closes and marks. You adjust it. You take off when there's 4 and there's no contact, you go to 3. 3, there's a contact, you take it off. So this idea of using the T-scan, biting into the sensor, I'm not biting into a sensor. I'm biting into 20 micron paper, and I'm having teeth touch teeth modulated across a 20 micron piece of film. I'm not biting into a circuit. Not that, and that gets you close. And I'm just saying, why does it work so well, the T-scan? Well, think about how wide the PDL is, and how much little micro movement you can have of the tooth, and that thing's a great tool. But I'm just saying, if you really want to get these contacts down and perfectly loading, really at the same point in time, you use the shims. You have to use 8 micron shim stock, and you have to use, I use 20 micron AccuFilm red and black. I can't use one color. In fact, what I do is I use all of those. I use the thick 200 micron Bosch. I use the red and black AccuFilm, and then the principal guideline technique. The principle is the contact. The guideline is we have to mark it, and the T is technique. Do I use paper? I'm going to use digital. The PDL is 15 to 38 microns. It deforms as much as the contact of the tooth. And so there's a sensitivity thing there that's just, interesting to think about. How do you use that practically? You put the shim in, the patient gently closes, and there's the first contact on that mesial marginal ridge. I did this over 10 years ago in England. We did this with a patient. I put shims in, we used a T-scan, we marked the same contacts with my shim technique that I learned from Jim Benson and Bob Lee, and there's the contact. And that's going to be the heaviest contact too. And so I can get that contact with my shim. I can use it no matter what I do, different thicknesses. And then the other thing I wanted to share was in bioaesthetics, our idea is we use this VOTE, vinyl occlusal test system. You have the patient occlude into uncured polyvinyl. And what that's going to do, that's going to create an analog of the space around the contacts. And now you pick that up and hold it at the light, you measure it with a caliper, and what you're going to see is the space around contacts. You're going to see the space around contacts, and you're going to see where in that last little movement into and out of the contact, the light goes through the PVS differently. And so to me, that's a analog version of the DTR. Remember, I'm from Pittsburgh, so talk is cheap, and I'm even looking for the cheapest way to do things. This is a video that I got from, I've got 5 slides, I think. This is a motion MRI from Ron Roth.
No for the wine, though.
And hey, I've got my Zubrovka, I got my Polish vodka here, getting ready. It's getting ready. And that slide's got to get out there. Get out, get out, get out. I'm going to go to the end here. Oh, I was right there. I'm sorry. Okay, 2 minutes. Here is my patient, Sarah. I finally get to measure her. Yeah, her nasolabial angle's a little flat. She only had one jaw surgery and a mandibular rotation and a genioplasty. Wouldn't be the surgery we'd do for her today for her airway and for her face. This is an amazing treatment. This is from 1980. This is from 1983. I started treating her in 2003 to 2005. I did her occlusal plane and composite. I changed it to porcelain, and I have 15-year follow-up of her. There she is in 2005.
Beautiful work.
And here is getting there. There she is. 2005, things that last in nature stand the test of time. That canine, we'll call it canine disclusion or canine guidance. Don't think of it. When you say that, you forget about the dynamics of the system and you lock yourself into a hole. You get pigeonholed. You aren't thinking biologically when you say canine guidance, because there it is in 2020. 2020, the same mouth. I've checked the fit of her teeth for 15 years. Every year she comes in, I put the little shims in. I look for a first contact with 20 micron paper and I check it with 8 micron. She's 70 years old now. I made her a new splint as a birthday present this year. There she is, 70 years old. Sarah Getz. That's my presentation. I did it for Dr. Lee. I did it for all of you.
That's so beautiful, brother. Honestly, this is a powerful follow-up with data. This is so powerful. You don't imagine how powerful it is. Believe me.
Say it one more time.
This is the first time I've ever showed this because I just updated this year. And I'm going to get a new scan for the next presentation. But thank you all. And,
thank you so much, Jeff.
This has been amazing, amazing. And my Zubrovka.
Okay. My God, cheers. I say I'm out of the beers. I was going to get some in the next break.
Lips. All right. Thank you.
Love you, brother. Thank you so much. Stay in touch.
Thank you, Jeff.
And we have another winner.
And Constantine is waiting. All right.
And then we have the new guest. So we start politely. And then we come, how is the word that I have to say? adventures because I cannot.
Well, let's see if Constantine brought some